All right, guys, it's my honor to introduce Lyndi Sargent, and she is the Maternal Child Resource Coordinator at Wentworth Douglas Hospital in Dover, New Hampshire. With a dynamic professional journey encompassing roles as a doula, childbirth educator, and registered nurse, Lyndi brings a rich tapestry of experience to developing and implementing innovative programs for families in the perinatal period. Or the prenatal period, perinatal period. Driven by a commitment to evidence-based care and striving for health equity, Lyndi spearheaded the successful launch of a pioneering doula program for patients. Her leadership has improved the quality of care for patients and has made her a valuable resource for other hospitals seeking to embark on a similar journey. Lyndi is dedicated to empowering families and improving the maternal and child health care experience, and we welcome Lyndi.
Hi, thank you very much for that welcome. I appreciate it. Just a little bit about myself. I want to share that I'm especially happy to be here today to speak to all of you in Arkansas because it is a state that I'm tied to in a deep way. Arkansas is the place that I had my very first child born back in 1995. She was born at St. Edward's in Fort Smith, and she has now returned to Arkansas, where she's a professor of psychology at Lyon College in Batesville. She doesn't remember living in Arkansas, but somehow Arkansas called her back. And she and her spouse are on their own fertility journey right now. They had their first IUI with a specialist in Little Rock. So I am deeply committed to supporting whatever I can to help everyone in Arkansas, but with a little place in my heart, especially for my own daughter and hopefully grandchild someday. Um, so I'll start by just talking a little bit about the doula. Sometimes I make these assumptions that everybody knows. Yes, go ahead to the next slide. So the plan today is a little bit of history. We're going to talk about what the doula does, some evidence, and then really focus more on some strategies of how you can incorporate doulas into your own system. Explore the models that I'm aware of that exist, and look at some steps you can each take starting today, really. Next slide. Okay, so essentially a doula is a trained person, and that gets a little convoluted in some areas. People think that you can just call yourself a doula, you can just call yourself anything, but it wouldn't be accurate unless you are in fact a certified trained doula. The certification process to become a doula is actually pretty intense. You learn quite a bit about how to comfort people, how to work towards equitable care. There's lots of specialty trainings for doulas these days. And the doula profession really came out of the 1980s. It was the time when, well, the 70s, right, led that off, where there was this whole shift in consciousness in general. And this is the time where a lot of women were saying, we want more power over our bodies. We want control over the decisions we make. And so they were trying to shift that healthcare that they were getting in birth. So that brings us to the start of DONA, which is one of the organizations you might be familiar with. It's one of the more well-known doula organizations, although it is not the only one. There are many really wonderful organizations that certify doulas today. It's just the longest standing, most well-known one. And it was started by some folks we probably know. If you've been in the birthing world for a while, you know these names: John Kennel, Marshall Claus, Penny Simkin, Phyllis Claus, Annie Kennedy. And they coined the term doula. So we didn't use the word doula. Prior to the 1980s, you just had a friend that supported you, your mother, a lay person that came in and supported you in birth. Then for a while, that didn't happen. You came into the hospital. There was this whole movement towards pain-free birth, which really meant you didn't remember your birth. It was highly medicalized. And this was the shift where we wanted to bring it back. So that's where the idea that doula became, that's how it became a thing. The first doula programs that supported people started emerging in the 1990s because that was the time that we started talking a lot more about birth equity. We started looking at the mortality rates between Black women and white women, and we said we've got to do something about this. So one of the things that we tried utilizing was these doula programs. But for the most part, doulas have been private for hire So they're only really available to your patients who can afford them, patients who understand the benefits of them. And that's what we're trying to work on today. How can we make it more equitable? How can every person who wants a doula or who could benefit from having a doula have access to them? So when we look at some organizations, you all have the benefit of Walmart. We don't have that many Walmart employees up here in New Hampshire, but the ones that we do have taken the benefit of doula coverage. It's my understanding that the reimbursement rate Walmart offers for doula services is still $1,000, which is less than a lot of the average doula fees, but lots of our doulas are willing to work with that rate in order to make this work for the patients. You, unfortunately, in Arkansas are not one of the states that has approved doula coverage through Medicaid yet, but I'm really hoping that you're heading in that direction. There's a publication that just came out yesterday from Arkansas talking about this. So there are people that are working on it. You probably are aware of them. We just approved Medicaid coverage in New Hampshire. It's not official yet in terms of that structure, but it's really going to bring access to doulas. It's going to make it more available. The challenge is there aren't enough doulas for all people yet. So we also have that thing to tackle. We've got to figure out how to increase the doula workforce. Next slide, please. So here's one of the challenges we've had in New Hampshire, and other states are talking about too, is the perception of doulas. People will have these preconceived notions that doulas have an agenda, that they think every birth should be unmedicated, that they really are superfluous, that, why can't the nurse be the doula? They tend to bring in those really high expectation parents, the ones with the birth plan, and you're like, oh my goodness. And the thing that I had heard in the very beginning is that they can be adversarial. So that was a bit of a challenge. We've worked through that here, and I'd love to hear, at some point, I'd love when we have some dialogue, if you're having that same issue there. And the accessibility issue is generally true unless you have a program in your state or at your hospital, but we are working on that. So that's one of the barriers I see. Next slide, please. So just to kind of clarify what doulas are trained in, it's pretty intensive. Again, I sometimes feel like people don't understand. They really do get a comprehensive education. Then they have to, in many organizations, if you can imagine how scary this is, they have to attend births, ask the provider to evaluate how they did, ask the parent to evaluate how they did, and then they can get officially certified after they've done all of those things. They do have a scope of practice and a code of ethics. They do agree to follow evidence-based research when advocating for patients. And as much as some people think they might, their role is not to give advice, it's to provide information and encourage people to make their own decisions. It's really no different than what we do, is their role in terms of that. We don't, as a medical professional, as an RN or an OB or a midwife, you can give a little more information in terms of some of the risks, benefits than what a doula can, but they can still present the evidence. All right, next slide. These are some of the organizations that have come up in the more recent years, really focus on diversity, equity, and inclusion. There are doulas that only attend loss births, so known births where there's a loss involved. Substance use disorder is another place. We are now co-training doulas as recovery coaches because of the problem we have in the country. Yeah, you may not know this, but our tiny little state of New Hampshire is one of the states that struggles the most with substance use disorder. And so we have this program here where we co-train doulas and recovery workers to work with those patients who are identified and are in our SUD programs. The outcomes are remarkable because they don't only offer the prenatal education and the birth support, but they offer the coaching in terms of maintaining their sobriety through their pregnancy and postpartum period. They have specialized doulas for mental health. There's a lot of cultural competency trainings that we didn't see in the early programs, and reproductive justice is another area that has been a focus lately. Next slide. All right. So when we talk about what is a high value model for doulas and for, and how they are, in fact, part of that high value model for care. When we talk about a high value model, we mean patient centered, evidence based, and avoiding wasteful or unnecessary spending, right? The doula supports that in so many ways. One, because they improve health outcomes. They are cost effective. We've seen evidence for it. Um, they address birth equity and they enhance the experience of care, which for some people that seems a little fluffy, enhancing the experience of care. I don't mean enhancing it like their birth is a spa day. It's a little bit more complicated than that, and we're going to talk about it. Next slide. So here is the evidence. This is the stuff that speaks to most of us, right? From the very beginning of time, when the original founders of DONA looked at studies on doula, at the time it was not called doulas, at the time they called them continuous labor support. They saw a decrease in cesarean risk, which I know is something you all are focusing. And that's a significant number, 39% decrease when you have continuous labor support during your birth experience. 35% decrease in reported negative birth experience, less use of pain medications, lower rates of instrumental birth interventions, shorter labors, decreased perception of stress and anxiety, and 22% lower preterm birth rates. And that's not if the doula is just with the person for birth. Those are special statistics when we look at including your doulas in the prenatal and postpartum care. And I can certainly explain how that happens there as well. We also see higher APGAR scores in the infants that are born, increased initiation of breastfeeding, as well as higher rates of sustained breastfeeding at the 3-week mark. Greater satisfaction with birth, we talked about, and the improved infant outcomes. The March of Dimes has a strong statement on supporting doulas for this reason. All right. So how does it happen? Yeah, go for it. So how does this happen? This is I should give credit to Rebecca Decker of Evidence Based Birth has a similar uh, slide available for people to look at. I wanted to talk about how this actually happens. So when you have someone that you trust that has good information and supports you through labor, many things happen in this whole cascade of labor. First of all, we have increased oxytocin. When we have less fear, when we have less stress, we know that that hormone loop that we need for labor to occur happens more effectively and more smoothly. When you have someone who understands the benefit of mobility in birth, they get you up and they get you moving. That decreases pain. All of these things work together to increase a person's agency and a sense of safety, decrease their anxiety. When you look at those, that top light blue category, those things point to a decrease of needing interventions to augment labor. We know if people get up and they move their bodies and they're not just laying in bed during labor, we are less likely going to need to augment their labor. There's a decrease of epidurals. We see shorter labors, and all of those things come down to that decreased cesarean rate, better infant outcomes, higher satisfaction of birth. And the other or newer evidence that we're looking at these days is that there's a lower risk of postpartum depression and anxiety as a result of doula support as well. Next slide. And if you're anything like me, I've been in this birth world for a very long time. You've probably noticed that people are way more anxious than they used to be. They're coming to childbirth classes and prenatal appointments with a list of questions a mile long, and they heard this and they read this, and I'm so grateful I had my own babies before social media because that was a thing. But we're seeing higher levels of anxiety and stress, and the doula really does help calm those places in these people and get them to a place where they feel more confident going into their birth. So when we talk about enhancing the experience of birth, we're not really talking again about I get this a lot when people ask, what does a doula do? Even some of the nurses and providers that I work with will say, oh, they come in and they give you foot rubs and they bring in essential oils. So then I think everyone thinks this is like a spa day for birth. And yeah, they do those things if that's called for. But really, what they do is they provide a sense of agency with the people that they work with. It gives them a sense of personal security knowing that they have a person connected to them. They feel respected and connected in a different way to the doula than they do with the rest. When they come in and I'm the first person, they've never seen me and I'm their nurse for their birth. They don't know me very well. I don't know them very well. I'm going to do my best to get to know them. But the doula's been working with them. They have a relationship. It's very, very different. Next slide. So cost savings is where I like to talk about this because when we try to implement these programs, particularly in for-profit organizations, we need to sell this, right? I care much more about outcomes than I do about cost savings, but you can't talk about just outcomes when you're dealing with leadership in facilities and community organizations. So how do doulas save costs? We reduce cesarean births, and that is a cost savings. Patients go home faster with a vaginal delivery, so we can get another patient in that space. There are fewer readmissions for patients who have had a doula and have doulas following up with them postpartum. Shorter hospital stays we just talked about. There's greater attendance at regular prenatal visits, which does lead to cost savings because you're identifying things sooner. So when a patient has a doula, just a perfect example, at another presentation, someone challenged that just the other day. They check in. So if a patient says, no, I can't get to my appointment this week, I don't have a ride, or I don't have enough money for gas, most of the community-based doulas in programs that are working with our higher risk population have resources. So they can say, okay, let's look at the resources. What can we do to help you get to your appointment? Better, and if they can't, then they say, okay, so can you make sure you call your doctor? We need you to cancel that appointment and reschedule for a time that you can get there. So rather than having a bunch of no-shows, you have patients that are just delaying care a little bit, but they're still making it to their appointments. It's really important. And that of course leads to fewer unscheduled outpatient visits, fewer urgent care and emergency department visits because they have someone to bounce off some decisions and guide them in a direction. The increased initiation of breastfeeding saves money, same with maintaining breastfeeding, and certainly having less preterm births is a cost savings. So we want to keep that in mind as well. Next slide. All right, so I'm not going to read these to you, but there are links to all of these studies. These are just some of the studies that talk about the benefits of doulas in birth equity. There are so many models of programs that are out there, particularly addressing Black women and bringing bringing some equity there. We have, like I talked about, the substance use programs and our low income and folks that are identified at higher risk. So when we look at putting together those people at the highest risk in our systems with a doula, we're improving outcomes remarkably. And we cannot ignore it. We just can't ignore it. The evidence is there, it's real. It's a little bit complicated figuring out how to incorporate doulas into our systems, but it can be done. So I want you to know and see the evidence to just maybe further light a fire about why this can be so important for our patient outcomes. All right, next slide. Couple of other, you just have to do a Google search. Some of these programs are programs I've talked to and visited that I really love. The one, the doula support, the one that it's at CVMC. So that's a Vermont hospital. They got a large grant to provide doulas for every person who was receiving services through their mental health program there. Phenomenal program, really well done. My hospital is a small hospital that's owned by, or I should say owned by, We are a part of the Mass General Brigham and Women's System Partners, and they have a phenomenal program that aligns people who are of color with doulas of color. So getting improved outcomes there, and we're seeing it all over the place. So next slide, just things to look at. Okay, so I think this is more the meat. Hopefully I sold this idea of what doulas do. This is more the meat of what I want to talk to you about is how can you make this happen in your own communities? So there are several models out there. The majority of them land somewhere in here. There are private doulas, they're hired out of pocket. Patients choose that, obviously limits the availability to only those who can afford it. I was looking at the doula rates in Arkansas just the other day, and they're actually pretty comparable to here. It looks like your doulas are getting anywhere from $1,000 to $1,600 per birth. Um, I say that out loud, and I've had people say, "Oh my gosh, I'm in the wrong career." But if you think about the time that the doulas spend with patients, that's actually not a whole lot for reimbursement. They're spending time prenatally with interviews, phone calls, and then they commit to the birth, whether it's a 6-hour birth or a 26-hour birth, they're there. And then they do postpartum follow-up as well. So when we do that out, math wise, it's not actually a lot of money. It's a relatively affordable program if you can afford it. Then there are community-based programs, and those are public and privately funded. There's oftentimes there will be groups of doulas that will come together, and I think you might have somebody speaking afterwards that might fall into this category a little bit. And they work together to provide services to any person who wants them, regardless of income. So they might have other funding sources like grants, donations, things like that. They provide a no or low cost doula services. And then there's hospital-based programs. That's similar to what I run. So I would call mine a hospital-based program. However, our doulas are not employees. They are what we deem persons of interest. So they are affiliated with us. They have a contract with us, and we pay them at a contracted rate. And that was by their own choice. So I'll go into that a little bit more. But the funding for those programs is going to have to come from somewhere. So it either comes from philanthropic funding if you have that at your hospital, or it comes from the capital budget. And that can be a little trickier to get, but there are hospitals doing it. And then there's, of course, insurance coverage. So we can encourage our patients who have access to insurance coverage to use it. So TRICARE, your military, although, well, you still do have military there. We were stationed in Fort, Fort Chaffee, Fort Smith, which closed. So I was thinking that that's closed, but you still have the Air Force Base in Arkansas. So your TRICARE patients, your Walmart employees, your CVS employees, your Microsoft employees, they all have benefits if patients know about them. And then if you have the doulas in your community to cover them. So just a little bit about my program and why I decided to do it the way I did. We were a small community-based hospital. We had about 900 births per year. And then a hospital near us made a tough decision that unfortunately they lost a lot of their market share when they made this decision. And suddenly patients were leaving them and coming to us. And we went from 900 births that year to 1,300. It was a huge change for us. And we saw our cesarean section rate go up. That was the primary thing that we saw. That was when we looked at how this affected us. We also saw a lot of staff leave. So there was staff dissatisfaction when everything got a little chaotic. So we needed to bring it back into balance. And having been a doula in my lifetime and part of my history, I thought, why don't we bring doulas on board? Because what we're hearing from our nurses and our midwives is that they don't have enough time to give the care to the patients that they want to give. Alongside this was another complication. We went from one medical records charting system to a whole new one, which we know how that goes in our world. New change. So we had this huge influx of patients, and we were also switching medical records systems, and it just was hard. So we brought in some doulas temporarily to see how it went, and it went amazing. It was a satisfier for patients. It was a satisfier for our staff. And so we wanted to make this a little bit more sustainable long term. And what I did, is went out to the community, to my doula community, and I said, how do you want to do this? You know, if I can get physicians at the hospital approved in our capital budget, would you like to work for us? And they said, no, actually we don't. We like being independent. That's how we like to do our work. So we came up with a compromise. We made them contractors. They still get to have their independence to be hired by private patients. And then they also work with what we consider our scholarship program. And that program is funded through philanthropic funding. So I receive about $50,000 from our sort of our grant section of our hospital each year to provide doulas to any person who's referred to the program. We have a whole host of list of things that would trigger a referral to me, and then I get the referral and I work through it that way. We provide a sliding scale and completely free coverage depending on the person's situation. It's worked now for 7 years that way, and it's been wonderful. We've really loved it, and we've even floated the idea of inviting doulas again back on and saying, let's give you positions, and they just really don't want that here. That doesn't mean that won't work other places. So in some hospitals, they hire doulas to be employees, and the doula is on the floor or assigned to a caseload. There's a whole lot of different ways to do it, but we've kept the doula relationship pretty consistent to what a doula relationship looks like. We assign these patients come to me as a referral. I find out which doula has availability. I assign that patient to that doula, and they take it from there. They build the relationship, they do the work with them prenatally, and then they follow up with me postpartum with a report, so I know how it went, how we keep our statistics and our program going, and it works great for us. That hospital that made that tragic decision that flooded people over our way for a while there saw what we were doing and said, maybe we can get some of our people back if we do this. And they created a program where their doulas are in fact employees. It still costs the patients. There's a fee, but it's a very low cost. I think it's $650. So it still unfortunately limits patients, but they seem to think that they're able to capture most of them. They do offer some scholarships, but not a whole lot. And that system's working out really well for them. I'm pretty connected to the person who runs that program. So if anybody here is thinking of that type of model, be happy to connect you with my friend Holly, who runs that program over there. All right, next slide, please. So when we are thinking about incorporating a doula program, we really have to think about all of our stakeholders. And it starts with the doulas in your community. Like I said, I had to go to them and say, what do you want? How can we make this work for you? We happen to have a pretty robust group of doulas in this area. It's not that way everywhere, but there are some ways to grow the doulas in your area. We're going to talk, I'll give you some information about that too. It's certainly your patients. What do your patients want? How do they see this working into their care? And then it's your providers, potential private funders that might be out there, your insurance providers. You got to talk to administration, policymakers, government officials. These are the stakeholders. So when we look at policymakers and government officials, this is where, if we're working towards in each state getting Medicaid to cover doulas, we can make a difference. So talking about it, getting it on the agenda. It took us 4 years in New Hampshire to get it approved. We just this year approved coverage for doulas and 12 months of postpartum care through Medicaid, which is remarkable. So now folks can continue to come back for more visits, and they can have breastfeeding, lactation support for that 12 months as well. Big changes for us we're really excited about. Next slide. So barriers are going to be there. I think these are the ones that I hear about the most. Lack of knowledge about doulas, which is what I'm here to talk about today, and how it really truly does impact patients. It's not just a fluffy thing to do. It's really helpful. Capacity and competing priorities. We have so many agendas in the hospital and so many things that we're focusing on. This may not be a priority, so it has to become somebody's priority. Somebody has to keep it on the meetings, has to keep bringing it up to leadership, keep bringing it up to the providers. Yeah, sometimes I felt like I had to wear them down a little bit, but it worked. We got there. The capacity, doula workforce is a big deal. There aren't a lot of them. And the reason why is because it's very difficult for many private doulas to maintain um, work-life balance. If you're on call all the time, it's pretty difficult to maintain that for a long period of time. And if you're not getting reimbursed and you have a lot of people asking you to do free care, which happens often, um, it can be hard to stay successfully in business. And then again, I run into this all the time, administrators and healthcare providers struggling with seeing doulas as a priority. It's not always seen, again, it's seen as a little bit fluffy, but if we look at the evidence, we cannot deny it. They really would be an incredible part of the healthcare team once we include them. Next slide. All right, so here are some steps people can take now if you're saying, okay, maybe, yes, let's do this. First of all, you got to know who's in your community. Reach out to your local doulas. Ask them how they run their business. Ask them if they're interested in getting involved and how maybe you could work together towards some sort of a program that serves your population more. Invite them to roundtables and grand rounds. Look up funding. So one of the things I want to share with people, and you may already know about it, is there is a federal grant. It's still forecasted. It's been forecasted for a while, but they keep telling me it's coming, where you can apply for funding to not only provide doulas to your community, but train doulas in your community. So there might be a way to find a group of people who want to do this work, use that funding to train them, and then have them come to work for you. That it's a federal grant. We're supposed to be able to apply sometime this summer. I'm hopeful. Um, Refer patients who have access to doulas. You can start right there. Once you know who your doulas are, if you know you have a patient who's coming in who has coverage through Walmart, let them know. Do you know that you can have a doula for your birth? And let me tell you why that's helpful and what doulas do. And then connect them or give them, referrals to the doulas. Include doulas where you can. That's another step. So when our hospital really embraced our doulas. This is actually a picture of our core doula team right there. They're phenomenal. And not only do they work with our patients, but they come in and they train our staff. So they are all spinning babies educators. Most of them are CLCs. They come in and they provide labor support training for all of our new hires. Particularly, this is the first time in 15 years that we've been hiring new grads in OB. And so those new grads have no labor support experience at all. So our doulas will provide, I apologize if you can hear my dog, will provide training for that. And then discuss the benefits of doulas with anyone who will listen. Thank you for listening to me today. Share it widely if you can. All right, next slide. Okay, so this is again thinking outside the traditional model. You can include doulas in your perinatal education. Our doulas also are our teachers. It's been really difficult. Long time ago, the nurses were the teachers, but with 12-hour shifts, when I first started, we had 8-hour shifts. So I could be on the floor for 8 hours and then I could go teach a prenatal education class. I can't do that anymore. So we had nurses dropping out of teaching because they couldn't fit it into their 12-hour shift schedules. So our doulas teach most of our classes and they're paid for that service. It's a fabulous service and it's a great way for patients to be exposed to doulas. again, they provide training and labor support. Another thing that we've done is we include doulas in providing discharge planning for our patients. So one of the press ganey dissatisfiers has always been speed of discharge. So our leadership came along and said, how can we make this better? Well, why don't we do a discharge group? We put our families together in the conference room, and the doula comes in and goes over a lot of the stuff that they can do. There are some things only the nursing staff can do, but there is quite a bit that those CLC trained doulas can do to speed discharge. And then they also run some of our support groups. So they run a prenatal loss group. I have a doula who's specifically trained in loss. She's amazing, and she runs our monthly loss group. She puts on a ceremony every year. So we can incorporate them and still improve outcomes, even if we're not ready or able to invite them into the system in any other type of model. These are some soft entry points that we can do in order to help. All right. So I end with this. I love this quote. If a doula were a drug, it would be unethical not to use it. And I think hopefully my passion for the importance of doulas shined a bit. But I'd love to take any questions that folks have in general or specific to our program.